some vasoactive agents to get our patient in shock through whatever's going on and maybe start working on fixing the problem. What are we going to do, and what do different agents that we have, what are their special properties and things like that? Let's just have a brief overview of some of the stuff that's most commonly used, okay? 99 times out of 100, you've got a patient coming in who's hypotensive. The first drug that you're reaching for after you've tried to resuscitate them appropriately is going to be norepinephrine. Brand name Levophed, you'll hear that used interchangeably around here. Levophed is primarily a vasoactive agent. It's going to increase your SVR, okay? It's going to get those blood vessels to clamp down. It's part of a family of adrenergic active agents, okay? You've got epinephrine, you've got norepinephrine, you've got phenylephrine, you got a lot of things that end in ephrin, okay? And they're all slightly different, but what you need to know is that norepi is our first line agent. Why? Because the data says that in septic shock, norepi has better outcomes. Pretty much it. But because that's the case, and because most of the time our patients are coming in undifferentiated shock, this is the guy we're reaching for. It'll raise your blood pressure. It will also very mildly raise your heart rate. It does have some inotropic activity, okay? Doesn't really do a whole lot from a contractility standpoint. It's not going to make the heart squeeze any harder than it's already doing, but it's going to give you that afterload and mildly increase your heart rate, okay? And this is first line, certainly in septic shock, but often in undifferentiated shock, okay? The one time you might not reach for it is if you have a patient who's extremely susceptible to tachyarrhythmias, okay? For that, you've got phenylephrine or neosynephrine, okay? Sometimes we just call it neo, and that's purely an SVR agent with absolutely no effect on contractility or heart rate, okay? Most commonly used for us in the setting of intubation, just to prop up somebody's blood pressure real quick, but occasionally used in drip form to help out our patients in shock if I'm really terrified of a tachyarrhythmia. Sometimes you just got to go back to the original. In this case, the original is epinephrine, okay? Epinephrine does it all. It's the catch-all thing. It's going to raise your heart rate. It's going to raise your systemic vascular resistance. It's going to raise your cardiac contractility. It's fantastic in certain situations, okay? Knowing what it does will let you know when it's time to reach for it. And in this case, epi is often our second or third line vasoactive agent. We'll talk about the second line one in a second. Sometimes it's our first line contractility agent, and often it's our first line chronotropic agent. So if I've got a patient who's got symptomatic bradycardia, ACLS algorithm, if you remember that, epidrip is one of the drugs that you can reach for first line. So outside of the adrenergic agents, you've also got vasopressin, okay? Vasopressin is an adjunct that also raises systemic vascular resistance. It does a few other things too, but you should think of it as your second line agent to add on to your first line agent, whether that's norepi, potentially phenylephrine, but most often, especially in the setting of septic shock, you're going to be reaching for vasopressin to help out and augment the effects of norepinephrine. When we do that is a subject for another talk, but I want you to think about this as second line for that. It also does tend to help sometimes in your right heart failure patients. Again, we don't have to get into why, but I want you to think of this as second line for BP to go along with that first line agent of norepinephrine. Doesn't have a whole lot of effects here. You'll still get tested on dopamine, but in real life, we don't use it much here in the medical ICU, so I'm not going to spend a whole lot of time on it. Suffice to say, dopamine is a drug that has different effects along this spectrum at different doses. And because it's so finicky with dose-dependent effects, it's fallen out of favor a lot in the medical ICU. Getting into some primary contractility agents. Dobutamine is a drug that causes the heart to contract harder and faster. You're going to get more of your bang for your buck here than here, but you're going to have an increase in both. And when dobutamine is started, especially early on, the very first effect you're going to see is actually a decrease in systemic vascular resistance. Sometimes in a primary cardiogenic shock patient, that's all you need to do. But if you have a primary cardiogenic shock patient who's also hypotensive, you may not be able to get away with just starting dobutamine on your own. Okay, so I want you to think of this as potentially first line for cardiogenic shock, or certainly one of the drugs in your armamentarium. But unlike epi, for example, which is going to raise all of these parameters, dobutamine is going to knock down your systemic vascular resistance as you go. Often it's started in conjunction with low-dose norepinephrine until the blood pressure has a chance to catch up and the inotropic effects and the chronotropic effects of the dobutamine kick in, offloading this compensatory decrease in systemic vascular resistance. Another inotropic agent we will use sometimes is milrinone. Milrinone is another agent like dobutamine that's going to cause the heart to contract harder and faster and decrease systemic vascular resistance. Milrinone has a slightly different pharmacologic route than dobutamine does, and for that reason, sometimes it's reached for first line in right heart failure patients. The thing that's most important to know between these two is that dobutamine is going to work in about 15 minutes, and milrinone is going to work in about 4 hours, and its effects are modulated by renal function. So in a patient with kidney failure, the milrinone effect is going to be wildly different than somebody with normal kidneys, okay? So 15 minutes for dobutamine, 4 hours for milrinone. You can imagine in a patient in an acute shock state, it's going to take me some time to get milrinone up and running, so it's not often the first time I'm going to reach for. A lot of times, these are your chronic heart failure patients, your chronic low-dose shock patients, those pulmonary hypertensions, those people with an EF of 10% that are otherwise compensated that need to be on some inotropic agent that are getting long-term milrinone. You can use it. There are times in which it is the first-line agent to use, but often because of the speed of onset, I'm reaching for dobutamine first. So at the end of the day, you've got some agents that you can reach for blood pressure. The adrenergic agents, depending on which one you use, have slightly different properties for all three. I'm usually reaching for norepinephrine first, and if I have a purely blood pressure afterload problem, I'm reaching for vasopressin to add on to my norepi at a certain time. If cardiac is the primary concern, then I'm going for dobutamine, potentially milrinone, but most often dobutamine or epinephrine. And if I'm using dobutamine and I have concerns for afterload in the interim, a little bit of low-dose norepinephrine is helpful to get me to a point where I'm well compensated, and then I can always back off on it. In real life, we're often cross-titrating these drugs all the time as we investigate and get more information on what's going on with the patient. But in those crucial first 15 to 30 minutes, you know enough to know which drug to reach for in the acute setting while you're getting the patient stabilized and finding out more about what's going on.